Okay, well, thank you everyone for coming this afternoon. Our presentation will be on the ASA, CPOM, CMS, and you, patient safety at its finest. So I'm so happy to have an esteemed panel here. I'll start with my colleague, Dr. Nabil El-Kasabani. He's going to be talking about the role of subspecialties in quality measure development. He is professor and vice chair of clinical operations at University of Virginia, and he's vice chair of the Committee on Performance and Outcomes Measurement at the ASA. We're going to conclude with Dr. Richard Dutton. He is going to be talking about new quality initiatives in the private sector. He's an adjunct professor, University of Maryland, chief quality officer at USAP, and he's chair of anesthesia, okay, at Capital Regional Medical Center. And I'll be starting the presentation talking about what anesthesiologists need to know about the CMS Quality Payment Program. I am a professor of anesthesiology at Albert Einstein College of Medicine, Montefiore. I'm chair of Committee on Performance and Outcomes Measurement for the ASA, and I have a director role at my institution where I look at quality at the level of sedation services. So, okay, excellent. Okay, so the quality payment program in anesthesiologists. What's going on? Okay, so I have no financial disclosures, and I'm going to be focusing on three objectives today. One is to understand the history of physician payments. Then we're going to be learning about what quality measures are in the quality payment program for anesthesiologists, and ending up with the question, are we achieving our goal? Well, I'm going to start with a brief history of physician payment and quality. Back in the 1990s, pretty much physician payments were not linked to quality at all. It was really linked to volume, and physicians were paid differently based on your specialty. And then in 1997, they created this sustainable growth rate where they had one rate for all physicians, but again, quality was not a part of it. In 2006, then we moved into the Tax Relief and Healthcare Act, and then you began to hear about the fact that you were going to get a positive incentive if you reported some quality measures, and then it went to actually performing the quality measures. And again, this is just for physician payments. And then finally, in 2015, we have the system now, which is the Quality Payment Program that was stemmed from the Medicare and CHIP Reauthorization Act. So just to create the foundation, what we're talking about, these are really this is all based on the Medicare program. And know that the Medicare program has 4 different parts. And so we're really focusing on Part B payments, okay? So it's the allowable charges on Part B. So the quality payment program, when you think of it, imagine 2 tracks, okay? So you have the merit-based incentive payment system, and what Centers for Medicare and Medicaid Services wants us to achieve eventually is the alternative payment model, okay? So just be aware that sure, we started off with the traditional MIPS program, but they have this program that they created in the middle, or I should say recently, and that's the MIPS value pathway system, okay? So that's kind of like to make it a little bit easier to get into that alternative payment model concept. So let's talk about MIPS, okay? So who really is exempt from this, okay? Because everyone, is like, well, do I need to do MIPS or not? Okay, so if you bill $90,000 or less in Medicare Part B allowed charges for professional services, you don't have to participate in MIPS. Okay, if you take care of 200 or fewer Part B enrolled individuals, again, you don't have to participate, or you perform 200 or fewer covered services. And also, they'll give you a break if this is your first year as a Medicare provider, or if you're participating in advanced APM, which we know is a different program. So in terms of 2025, they have 4 components to it: quality, costs, improvement activities, and promoting interoperability. And they have divided it up into these different areas, knowing that we're going to be using, instead of the terms payment incentives, we're going to be using the term payment adjustment. So you can have up to 9% increase in your payment adjustments, or it could be negative 9%, knowing that this is a budget neutral system. So therefore, if everyone's doing well, everyone's going to be getting just a little bit. Okay. So for anesthesiologists, due to the fact that we are patient-facing, they allowed us to reweight our percentages, so that for most anesthesiologists, 85% of the time they're concentrating on quality measures, and 15% of the time they're concentrating on improvement activities. Okay, so this is the anesthesiology-specific measure set. So these are the measures that anesthesiologists can submit to CMS in the MIPS program. And again, you can do up to 6. They prefer you to do 6. I'll go into detail a little bit about them. So for the smoking abstinence, they really want to make sure that we have outcome measures as opposed to just process measures. So this is our intermediate outcome measures, where we're looking at the percentage of patients who abstain from smoking the day of surgery. And how do you figure out that they have abstained? Well, you ask them. So they will allow you to do a checkbox and say, yes, the patient abstained, or you can actually draw a sample and you can look at their exhale, or you can just look at their exhale carbon monoxide level. And again, this is for adult patients. And the beauty of this is that as the anesthesiologist, you can do this, or you can get help from the people in the perioperative setting, okay? So they want you to talk to your patients before about smoking abstinence, so therefore when they come on the day of surgery, you can have that conversation and get the results. Another outcome measure, which we're happy to say we were able to maintain. We just had a meeting this week with CMS, and they are always interested in getting rid of measures, but we were able to keep this measures because we really felt that it was valuable and meaningful to our patients. And the thing about it is that we want to make sure our patients are normothermic upon arrival to the PACU or within 30 minutes prior to going to the recovery room. Next one is postoperative nausea and vomiting, another patient-centric measure, okay, where if patients have risk factors like 3 or more, then you should be getting 2 antiemetics from different categories. And for the pediatric patient population, if they have risk factors, 2 or more, they should also get antiemetic prophylaxis. And for multimodal pain, for adult patients, we want to make sure you're using 2 or more opioids, or 2 or more non-opioids, okay? And that could include things like neuroaxial blockade, peripheral nerve blocks, it could be acetaminophen, things like that, okay? In terms of our data registry, we work with the Anesthesia Quality Institute from the ASA, and we're happy to say that we got many new measures that have come up for approval this year. So these are measures that we're going to be testing, and eventually we hope to use them in the MIPS program. So the quantitative trainer 4 monitoring, we have preoperative cognitive assessment in the adult patient, as well as the continuation of buprenorphine in surgical patients. Dr. Lakaska-Bani, he'll talk more about some of the regional ones that have been approved for the QCDR. So that's the beauty of CPOM. We're always coming up with something that's meaningful for our patients and something that anesthesiologists know will make a huge impact and that we have control over, okay, in the perioperative setting. Now, let me give you a brief overview of what's happening with regards to MVPs. Know that MVPs are more geared towards the patient voice, and know that they have this foundation of looking out for population health and making sure that we look at interoperability. In terms of population health measures, they want to look at readmission rates as well as the admission rates for people with chronic diseases. Now, these are the quality measures for the MVP, which is the MIPS value pathway. Again, some of them are from the MIPS program, so they were all on board with us bringing over the true and tried measures from the MIPS program, but we have a couple of others, like patient-reported experience with anesthesia, intraoperative hypotension, for patients having non-cardiac surgery, so that's a mean arterial pressure less than 65, the use of low-flow inhalational gases, as well as screening for social drivers of health. Okay, so this is now that next system where this is the goal, that alternative payment model, okay? So CMS realized that many institutions were trying it out in different ways, and this is something where that the institution has to take more risks because you have patients from socioeconomic status that may be a little bit more challenging. These patients are a little sicker, and so people were realizing, they may not be making as much money taking care of these patients. So CMS wants to make sure that we create a system where we don't have fragmented care, that we're trying to really optimize spending and really have better communication amongst all different areas. So what they did in 2024, they said, okay, let's try a new alternative payment model. They asked a few different hospitals to, it was like they voluntold them to get involved in this. So therefore, they will be looking at a couple of different procedures, okay? Those patients that are having CABGs, bowel procedures, orthopedics procedures, as well as spinal fusions. And they'll be looking at readmission rates, complication rates for hip and knee arthroplasties, and really seeing are the patients happy after their procedures. And they're going to be evaluating the PSI 90. And for those who may not know what a PSI 90 are, this is a list of 10 of them, and you'll see that there's some things that we can control, okay? And remember, this PSI 90 is similar to what the hospital really is always focusing on. So I think it's important that we realize that as an anesthesiologist, we can play a role in terms of showing our value, in terms of improving the quality and care of patients in the hospital setting. Okay, and always there's a question of, are we making progress with this whole program? There's pluses and minuses to it, and we have to be honest that, everything is an evolution and there's always room for improvement. So here, this is a nice study that looked at the association between the MIPS system and comparing it to hospital compare, all right? And they tried to figure out, in terms of your hospital compare scores, is there a relationship, okay? And they found out there really is no statistical significance between those at the top or the bottom in terms of the MIPS scoring and how well they did in terms of fulfilling all the quality measures for a hospital compare. And in terms of the fact that this is supposed to make it more cost effective, in terms of the fact that we're communicating with each other, and they projected that between 2010 and 2019, we would save $2.8 billion by utilizing this program, and we actually spent $5.4 billion. So what does that mean? There's room for improvement. However, I think we should be at the table while they're making these changes. It's something that's in the system now and is going to be around for a while. It's not something they can just cut the program completely. So I think it's key that anesthesiologists are the ones who are out there making the quality measures for CMS, or else they will make it for us, okay? And we don't want to have that happen. Okay, so next we have Dr. Kasabani, and he'll be talking. There we go. Okay, excellent. Okay.
Thank you, Velma. Okay, one thing that really amazes me, just especially when you join the CPOM, the number of alphabet soup that you have to keep track of, and all the acronyms, and also if you really paid attention, Vilma mentioned the word measure in her talk about 39 times, right? So what is that measure thing? What are we talking about? So again, I work in the no, okay. I think so. So I do work in the University of Virginia. If you don't know where Charlottesville is, it's just almost exactly in the middle of Virginia, about 2 hours south of DC. Okay, a lot of college sports, very small town, 50,000 people, very cosmopolitan because of UVA. I have no financial disclosures. So what we're going to talk about today is we're going to try to define what is the quality measure. What is it? And also that we're going to go through the life cycle of a measure from the minute it was born until the minute it is retired, or go peacefully, okay, into the a different realm. And also that we're going to discuss the role of the different disciplines of anesthesia, and with a little bit of a focus on regional anesthesia. My disclaimer or my bias that this is the bulk of my practice, so we're going to talk a lot about regional anesthesia, about acute pain and chronic pain, right? But also that we're going to mention the other disciplines as well. So I think this could kind of just set the stage very well for what we're talking about. If something that we cannot measure, we really cannot improve. So think about what we do in a day-to-day and whether you really can measure the performance that you're doing. Well, you put patients to sleep, you wake them up, okay, it's great, but are you doing a good job? Yes, I am. Okay, really? I think so. Really? All right, I'm not sure, all right? So it just keeps going from one. Okay, so there has to be some sort of an objective criteria, or objective measure, for how to measure the performance of Nabil versus Vilma versus Rick, who's doing a good job and who's not doing a good job. So a measure, just very simply, okay, I'm not gonna just belabor reading the definition, but you can see it's tools that we use to measure our performance, and they come in different flavors. You heard the word process, you heard about the word outcome, and you heard also the word about shared accountability, and you heard about the organizational structure, or what we call the hospital measures. This is all happen within the realm of what we do at CPOM. If we are talking about quality in general, I'm assuming that you're here because you are somehow interested in quality. We know that there are 6 domains for quality, and this is the 6 domains of quality between safety, timeliness, effectiveness, efficacy, and equity, and patient-centeredness. So what are these measures? What are they used for? All right. So you heard from Vilma that eventually on the far right side, actually right now, they can be used for payment. But this is not the only and the single reason that we come up with these measures. Because if this was the case, I will tell you that this is going to be very frustrating, because a lot of the concept and a lot of the measures that we come up with really do not feed into the quality payment program. But they can be used when they are tracked. A lot of you, especially if you are members of some QCDR, here's one more alphabet soup for you. If you're part of a data registry, whether it's something with the ASA, it's going to be called the AQI, the Anesthesia Quality Institute, or part of the MPOG, especially if you're an academic institution. Most of you are going to get an email that you have, that many patient was called, that many patient threw up, that many patient had nausea and vomiting, and this is your score compared to the average. The average is 90%, your score is 85%, you're not doing a good job. And this is essentially used also for your MOCA and for your maintenance of certification. But also that you can use this for internal activity, for internal improvement activity, if you want to structure a quality program in your institution, irrespective of what subspecialty of anesthesia that you're doing, whether this is regional anesthesia, cardiac anesthesia, adult multispecialty, or whatever that is. Okay, so back to the measures. So when we look for measures, what is a measure? A measure is, think about it just in its infancy. It starts as an idea or a concept. And this is really what we're looking for. We're looking for measure concepts, right? And a measure concept is something that you encounter in your day-to-day, something that you do, but you think it can be improved, a clinical dilemma that you think about. And there has to be a performance gap, meaning if everybody's pushing the propofol, everybody's pushing 100 milligram of propofol at least, and we're doing that as 100%, this is not going to be improved more than 100%, so this is not a quality measure, right? This is something that we have a room for improvement, a room to grow. There's going to be what we call a performance gap. It's going to be great if we're going to capture that from electronic medical record. So you don't have to have a special way to go out of your way to really document the measure that you're doing. And you're going to hear a lot from Rick about some of the initiative that he's doing in his practice about that. And also it's going to be even better, if we're promoting health equity, if we're still allowed to say the word equity nowadays, right? If we can promote the health equity between patient population that I'm providing the same care, irrespective of who you are, where you're coming from, and the patient coming to receive care, they're going to receive the same care in New York or Charlottesville or wherever they are coming. So this illustrates a life cycle of a measure since its birth, all the way to its retirement. So it starts an idea and then the development. And that idea, it just goes through the factory of measures. This factory of measures is a dedicated staff. This is what they do. They essentially generate a lot of the CPT codes for that procedure that's targeted by that measure. And they create a denominator and a numerator for your performance of that measure. And they really put it in a way that is going to be measurable. And then we put that for comment, and people give us feedback on that measure. This is good, this is bad, you can improve in this, you can do this. And we take these comments and we try to improve and edit these measures. And we then, if it's good and it's approved by the board of the ASA, it's submitted to the CMS. CMS, we say that CMS review them, but also remember that a lot of times you use a third-party vendor. It used to be the National Quality Forum, now it's the PQM. So now you have a measure. This measure is going to live for a while. A lot of people are going to be doing very well, but after a while, that measure is going to need maintenance, right? So we go back to our membership and say that, can we please look at the data? Has this measure been topped off or topped out? Meaning that we really did a fantastic job, that everybody now has exceeded performance and everybody now across the board is performing at 110%. And you go to the CMS, it's a tough luck, you cannot measure that anymore. You're not going to get paid according to this because everybody's doing it right. Very similar if you think about the payment when the blocks, now this is my bias comes right here, when the blocks started with ultrasound and then now they are saying, well, you're not going to get paid extra if you use an ultrasound because everybody does that right now, okay? So mentioning regional anesthesia, this manuscript came up in 21, and this group looked at 20 manuscripts, and they looked at what kind of quality indicators that was listed in the literature about regional anesthesia. And it turns out from the finding of this group, they have about 68 measures or quality indicators that they came up with. And this is a very nice illustration of the distribution of these quality indicators. And you see here, some of them falls into process, some of them falls into outcomes. And also they were able to redistribute, all these quality indicators based on the domains that they lie in, whether it's safety, whether it's timeliness, whether it is efficacy. So that really opened the way for some of the rethinking about these measures. I'm not going to just go through these. This is a busy slide, but just to give you an idea about some of these measures that they found in the literature and just to show you that this is really backed up by evidence. So I'm going to just take you on a journey and I'm going to tell you a story. So back in 2017, the ASA just said that we're going to do a TIP. And a TIP is a technical expert panel, or another alphabet soup, right? So that we're going to gather people that belong to the ASA and gather people belongs to ASRA, the ASRA PIM medicine, and we're going to put them in one room, and at the end of 2-day meeting that we want you to come up with some ideas or concepts for measures. Okay, that was the mission. So we took that mission and we came up with 6 concepts that to develop them into measures. That was back in 2017 and 2019. And this was the 6 ideas that came from that, including, but not limited to, the multimodal analgesia and the use of neuroaxial and or peripheral nerve block for total knee arthroplasty. So let's take that first one. This is something, let's see what's the evidence. Let's apply the concepts of the measure developments to that. So do I have an evidence to support that? So the answer is yes, I do. And actually, this is backed by a literature that is back to 2013, that it turns out, yes, it may be a little bit not as strong now, that evidence, but if patients go in for total knee and total hip, if they get spinal, maybe they do better, or maybe from a population health standpoint, that they're gonna do better. Do I have a performance gap? You bet. Look at the percentage of people in this country, who gets neuroaxial anesthesia. Mind you, this is data from 2013. So the numbers may look very different right now. So I have evidence to support, all right? Just that was one piece of evidence. I have a performance gap, and here are some more evidence to support for you. If you did neuroaxial, you may actually contribute to the decreased incidence of surgical site infection. And we did a couple of things, whether there are systematic reviews or not, but again, we have more data. And even from we're looking at the performance gap and just temporal trends in that. And you see that gap still existed, at least at that point, up to 2013. Okay, and not only that, right, this was also backed by some societal guidelines, not Anesthesia Society, but it's backed from some orthopedic societies, so it's good. So you have an orthopedic surgeon, actually they are saying blocks are good for total knee. It doesn't get any better than that, right? Okay, and they're actually saying the level of evidence is moderate. Okay, great. So we have all the ingredients to make a measure. So let's do that measure and let's create that. And this is what we came up with. This was probably that some number that you see, the EQ 156, the use of neuroaxial anesthesia and or nerve block for total knee arthroplasty. That was submitted to CMS, but it did not make it all the way to the MIPS system. However, it can be used as part of the reporting measures that goes into MIPS. One of the things that I'm personally very proud of is the concept about the multimodal analgesia, because when we were talking about this back in 2017, it was not as, this is now a very, very, very midstream, nobody even is gonna question the use of multimodal analgesia. But at that point, it was okay, do we have statements? Do we have guidelines? And actually, we did have statements and we did have guidelines, whether they were from the ASA or from multiple societies coming together. So we came up with the multimodal pain analgesia, which is the 477. That was also another measure that made it all the way into the MIPS. And just to give you an idea, how to measure it. So this is the flow chart of that measure, and if you really take a closer look, you're going to see how much a performance is met by using two or more of an analgesic modality other than opioids, right? And if you did that, your data has to be complete, right? There is otherwise, some of these patients are going to be excluded, and this is how you're going to come up with the rate. Now we're all talking about this from the ASA standpoint. Is the ASA the only player? No. You're all familiar with the MPOG, and the MPOG also came with their own set of measures. But also, it's not even that. Before that, we have the Joint Commission. That thing is going on its own, right? So here, so we have the Joint Commission, came up with a very similar measure, and the MPOG, came up with also the same concept of the multimodal analgesia. So what happened to these measures, the 6 measures that we came up with? This is the distribution. Okay, one of them became a MIPS measure, that's the multimodal pain management. 2 of them go to the QCDR. This is the qualified data registry, which in the ASA case, it's NACOR, right? And the 3 others has been used for internal improvement. So where are they now? because we can look at the data in the database and see what's the performance of each one of them. And you're going to see the performance of both the 156, the neuroaxial, and the multimodal, just based on the different years that we have data until 2023, just when we're preparing that talk. So this is the percentage, and you see that really we're doing a very nice job, and even with the multimodal analgesia, but we're still not at 100%. Are we doing a good job in providing the same care to everybody? Not too sure about that, and there is a room for improvement. And the way to improve that is to really infuse some of the elements of the health equity into the measures during the measurements as we are doing it as a lifetime. You heard from Dr. Joseph about something called the MVP. What's the MVP? Essentially, just you put a cluster of some of the measures together, whether they are improvement activity or they are measures. So, lay terms, I just am a simplistic guy, who sticks people with needle, and this is how I think about things. I'm just going to put a statement almost like a clinical vignette, all right, or a statement. This is based on clinical evidence that I hope that I made a case for you. Essentially, use neuroaxial, you do better, in terms of outcome. You may or may not, prevent surgical site infection, especially that should be folded in a care pathway. So let's see, how this is going to translate. So this is the statement, and in each one of those, this is the different measures, okay, as we go through them. And you can argue that this is my MVP. So this is a comprehensive product that I can submit to CMS and say, I want to get paid for total knee arthroplasty as a package. However, I think, I'm not sure where we are. I think that there is maybe a little bit moving away from it, into a different direction, but that was prevalent, at that time. Okay, so what are we doing now at CPOM? Right, so at CPOM, that we're trying to collaborate with all the ASA committees in the different subspecialties. All right, we're also trying to track or stock, the guidelines for any guidelines or any practice advisory that is coming out. Because if you think about it, this is going to be the core of the concepts that can make measures down the, down the road. And also, every year, there's an open call. So please, if there is something, a burning question that you have, and you see this open calls comes out, please contribute, and please just submit, one of these ideas. So that was 2017, 2018. Did we stop there? No, we did not. Okay, so what we did, you're probably very familiar with the dilemma of the buprenorphine and the methadone and the continuation. And also, you're very familiar that, these guidelines came out, in the last couple of years. So we have the evidence, we have the guidelines to support. So let's make a measure out of those. So the measure that we came up with actually for the continuation of the buprenorphine and methadone of these patients, that was submitted to CMS in the last cycle. CMS came back to us and said, can you combine these two together? We said, yes, CMS, we're going to do that, and we're going to combine them, and this is what we submitted to them, and we're waiting for them for the comment period to respond to us. Okay, so that was on the side of the pain management, especially on the chronic pain side. What about the acute and also regional anesthesia? On the regional anesthesia, something we were just talking about. This is a very common scenario. A lot of evidence to support nerve blocks and hip fracture, right? Especially for the elderly population. But actually, we never implemented that as a quality measure, right? And the performance gap here is huge. I did not put, unfortunately, some of the slides to indicate that, but I can tell you that it's less than maybe 20% in this country that patients with hip fracture that they get no blocks. So we submitted that. Again, we put an idea around it. We submitted to CMS. And this was a lot of groups, including the geriatric committee, including the regional anesthesia committee that contributed to that work, and that we came up with this. Yes, I'm biased to regional anesthesia, but regional anesthesia is not the only thing that we're focused on. We got a group of experts from the obstetric committee, and that we put them in the room, and we told them, please just give us your ideas and your best shot at coming up with some concept measures. So they give us 3 ideas, the first of which was the quality of recovery from a C-section, pain during C-section, and the bundle of care for post-dural puncture headache. And also, as you know, these guidelines that are represented by the infogram on the right-hand side of the screen, this was published last year in the RAPM journal. And with that, they give us a bundle for the care of patient with post-dural puncture headache. We submitted to the CMS, but unfortunately that was only granted to be an internal improvement activity for the various institutions. Okay. Again, when we look at different registries, MPOG also has their own set of the OB measures, and this can be found on their website. You don't have to register, you don't have to have a login, but this you can at least see what these measures and how they are made up of. So we talked about regional anesthesia, we talked about pain, and we talked about OB. Did we stop there? No, we did not. All right. We also reached out to the Committee on Critical Care, and we said, okay, give us some of the ideas. And right now that we are in discussion with them about some of these concepts, and really which one of them is going to be valid to put a measure around them. So this is an open call for you to action. When you see the call for concept measure, please give us your best shot. Please give us your ideas. These measures exist because of you. They exist for a reason. They are not just because a group of people come together in a room and they get to meet and just come up with a measure. And again, that you see they are here for a reason. And the reasons, I hope I made a good case for you that there is a reason that we're doing this. Thank you, and I am going to hand the mic to Rick.
Thank you. Thank you very much for having me. I got it. Yeah, let's see here. All right, so Vilma and I have done this panel several years in a row, and usually after she depresses everybody with the regulatory requirements, and then we'll have somebody talk about what's possible in academia and sort of what the best practice is in that world, and then I get invited to talk about the real world and how it looks. So I'm Rick Dutton. I'm Chief Quality Officer for U.S. Anesthesia Partners. I'm the head cat wrangler for about 5,000 clinicians nationwide, and trying to figure out how we're going to do our quality reporting, both, as you heard, for internal utility, like actually improving quality of our product, but also for all the regulatory requirements. And this is typically when I come along to talk. So this year, I wanted to hit 4 things. Reassessing MIPS reporting. You heard Vilma talk some about this. I believe we're right at the cusp this year, next year, for whether this system is even going to survive. And I think given a different government, like one that actually worked, we would be turning this over already. That was the intention. MIPS wasn't intended to last forever. And, sorry.
Yeah, it does that.
I'll be careful.
Yeah.
However, there's a lot of inertia in the federal bureaucracy right now, and I think we're going to be stuck with it for a little bit. But as you'll see, it's becoming increasingly less relevant and less predictable. Sorry, let me go back. Right, we'll talk a little about documentation. This is actually, if you ask my 5,000 partners what I could do to make their lives better, reducing their documentation burden would be number one, quite clearly. We'll talk about some research opportunities and what we're doing in the private sector to actually advance care. And then a few words on our biggest problem, which is the workforce crisis and how it's impacting how we deliver care. So I'll start with some data. This is our performance on MIPS in 2024. USAP-wide, I think we report to CMS as 15 different or 16 different state entities. So USAP of Maryland is where I practice. And each of those is a block of data that goes in. If you report to CMS as a group, if you do your quality reporting as a group, then you get an average score across your group, and whatever score you get, the penalties or incentives then apply to every member of that group going forward. So that's important because if you're earning incentives, you earn the incentives for the whole group. And that's regardless of whether those individuals are actually eligible to report or not, as you heard Vilma said. If you report as individuals, first of all, if you're not eligible, you don't have to report, and there is no penalty and there is no benefit. Our goal always has been to get incentives and earn them across our whole practice. This makes some sense. These are, whereas in prior years we've reported as many as 12 or 15 different measures every year to CMS, and what you heard Vilma say is they count the top 6, and that's an automatic process. You can report as much data as you want to CMS. They will find the 6 measures that give you the highest score. They will also find the mechanism for your group that gives you the highest score. We'll talk about that in a second. That's both a blessing and a curse right now. So these are the measures that were reportable from USAP, and for any given, I think there are about, I don't know, QCDR has about 25 measures in it, the Medicare said about 10. You have a slate, plus there are other entities that offer measures, different registries. You probably have 40 measures to pick from, but for any given anesthesia practice, only some of them are going to be reportable based on your infrastructure, your logistics. Can you measure smoking abstinence, for instance? Can you know whether a patient is taking methadone or buprenorphine ahead of time? Right, so there's a certain amount of finding the measures that are logistically feasible for your practice. As I said, in prior years, we've had a dozen of these. We're down to, what's this, 9 in 2024, and we're very concerned it will soon be 6 or less, which is going to reduce our opportunity to do well. You can see our absolute performance. That's what the bars represent, and it's by quarters, which is a little weird, but just kind of take the average for each of these measures of where we are. Most measures are topped out. That is, performance is at the 99-point-something% level, the mean, for us, and this is true nationally as well. And that has an impact on how they're scored and what happens. So I won't go through the specifics of this, but this is what's on our roster this year, or this past year. Now, what's been going on, as I said, we've had fewer measures to report, and this is because when a measure does get topped out for a while, first of all, CMS has been giving you less points for topped out measures. So even if you're at the 100th percentile for PONV prevention, for instance, you could only earn so many points in the system for reporting that measure. That's going away this year, we hope, and they're not going to penalize topped out measures. But the other problem, the bigger problem, is that when a measure is topped out for too long, CMS will declare victory. We have solved that quality program. We will send that measure to the Hall of Fame, and you can no longer report it, right? And you heard that referred to as well, and that's why you don't get points for giving the antibiotics on time anymore. Okay. And it is one of the critical functions of ASA and CPOM is to keep the measures coming. There is a reason we have to keep developing new ones and putting them in, because they're going away at a rate as well. Now, the biggest problem we've seen in the last couple of years is this middle point here, random results. So, as I say, the big CMS black box will give you whatever score it gives you based on traditional MIPS. So your top 6 measures roll up into a quality score. Your improvement activities roll up into a score. 85% is the quality scores, 15% is the improvement activities, but they may also apply a cost component to that. You saw the cost component on Vilma's slide. Anesthesiologists are supposed to be exempt from that. Supposed to be, but the computer doesn't always get that right. And if, for instance, your practice bills E&M codes for ICU care, or you bill pre-op anesthesia consults under an E&M model for patients you might see in the emergency room, for example, or your APPs do post-op pain management and bill for that. All of those things can suddenly make your group eligible for the cost component of the score, and you can have a random penalty appear on your scores for no reason and in no easily explainable way. USAP, which is very large, has had this happen to us several times in different states, and it is unpredictable and unaffectable, right? It's less than 1% of our total activity is causing us to have a 15% penalty to our score for the whole group. And we've appealed that. CMS has admitted they're wrong, and they won't change it. So there you go. Sorry, the slides do wander arbitrarily. The MVP you heard is a smaller subset of measures specifically bundled around this traditional concept. They're scored slightly differently. Sometimes your MVP score is higher than your MIPS score. Great, they'll give you the MVP score. And then the third one, and I don't know if this has happened to anybody in the audience, if the facility you do most of your work in, that is the single hospital that you do most of your cases in, has a higher quality score for hospital compare, the hospital performance measure, than you do for MIPS, you get the hospital score, which is actually a benefit, but is unpredictable again. And it is also somewhat weird, again, in the state of Texas. Our biggest institution is Methodist Hospital. It was a very big institution. They do very well. But for some reason in Texas in 2024, we're getting our quality score in MIPS is based on Methodist's hospital compare score. So again, less than 1% of our cases in the state of Texas resulted in our quality score. Completely unpredictable. There's no way to know that in advance. It's just the last few years when I look at our reports back from CMS and how we did, it's a random walk. This is obviously reducing morale in terms of investing in trying to improve this or investing in working in the regulatory system. This has been a big problem. The other variable is it turns out very few anesthesia clinicians are now eligible or required to report to MIPS. So when we started this 8 years ago, 10 years ago, when I waded into this for USAP, most of our doctors and about half of our CRNAs met one of those two thresholds that Vilma showed you, either $90,000 of Medicare billing or 200 cases. Today, it's almost no CRNAs and something like 5% of doctors. And the reason is they haven't changed those thresholds at all, but a large number of Medicare patients have moved to Medicare Advantage, and they no longer count. Did you know that? So every time you turn on ESPN and you're watching SportsCenter and they're advertising Medicare Advantage plans, that's because they're good for the payers and they want to move people to Medicare Advantage. That's worked, all right. However, the problem means most of us are not actually required to report to MIPS anymore. And again, we are looking, so the punchline of this topic is we're looking very hard at our investment in this at all and whether we should even bother. And it's we spend a lot of money on this. I just benchmarked that recently. Since I joined USAP 10 years ago, we have spent about $60 million on quality improvement activities, this system as a whole. And it's entirely possible that the $5 or $6 million a year we spend on this, we're not going to get back in incentives. So we're looking pretty hard at this right now. I'm sorry, that's bad news. That's the national landscape right now. All right. Moving on, documentations. Right, we all hate it. And we live in the information age. So it's very reasonable to ask, why am I wasting so much time documenting things? Why can't it happen for me? And this is very real and a big push that we are making. So what is USAP working on right now? We are working on how to reduce our documentation burden. And there are a variety of ways for it. Obviously, your vital signs should stream directly into your EMR, so you don't have to write down the blood pressure every 5 minutes. But there you can do a lot more than that, potentially. And AI is helping with this, so preloading pre-op notes based on health information exchange information on patients. You can go scrape all that up, crunch it down, produce a patient history for your pre-op note that just automatically appears there. We're building that. Golly, this is really annoying. OR cameras. We're just starting to pilot some of these systems, but you can put a couple cameras and a microphone in your OR and you can get rid of a lot of clicks on your computer. And we're starting to look at some of that. Timestamps, drug doses, Alexa, 50 of rocuronium, kind of thing. And we're working on that right now. And our goal, and we're aspiring to this, and I have a few sites around the country where we're piloting this kind of thing, clickless anesthesia records. It just all happens passively behind the scenes from you. And I think we're actually not that far from this, being able to do this reasonably well. And what a benefit for our clinicians if you got rid of all the documentation burden from us. All right, research. We collect an awful lot of data. It would be stupid if we just kept it to ourselves, so we don't. Obviously, we use a lot of it for operational information, OR starts and stops and utilization and how we staff and things, all built out of this. And there's 100 people down in the exhibitors hall who will sell you these systems one way or another. We do all those things, but also into real research. And these are some of the projects we're working on right now. We measure patient satisfaction, every case, every day. We send a survey automatically to the patient. It's all an automated system. We return 500,000 or 600,000 satisfaction surveys every year. This is a wealth of information, and we're starting to mine into that. We know what predicts anesthesia patient satisfaction. We can actually improve it, and we've demonstrated that. So we do specific training around that, feedback for our clinicians around that. And right now we're looking at the fundamental question: if you look more like your doctor, are your satisfaction scores higher? Because we have the data to demonstrate that. And I won't spill the beans. We'll be back next year with a presentation on this topic. But some friends at the University of Chicago and I are just about to write that paper. We have all the data right now. Similarly, USAP is big. Workforce is a huge issue, hiring and retention. So we just took my 5,000 partners, and actually over 10 years, it's about 10,000 people we've touched, and looked at when they joined USAP, when they left USAP, and why. And correlated that with everything we could think of about why they might stay or why they might go. Everything from salary compared to the local market to how far they have to commute to work every day, and how much overtime they do, how many weekends, et cetera. And we are building a model around this. It's actually being presented. There's a poster tomorrow on this topic. And then finally, we're just starting a language process. What language do you get your consent in? And how does that impact outcome satisfaction, things like use of regional anesthesia, other equity considerations in care as well. So lots of opportunities there. This was one we published last year. Drop benzo trial. Can we reduce the amount of gratuitous benzodiazepine administration to old patients, right? Something we're pretty sure is bad, but is still very common. Our baseline was about 30% of our patients over 65 were getting benzos, and over the course of a year, this was a quality improvement project, we lowered that to about 17% for our 2.5, I think the N in that paper was 600,000 older patients that we reduced benzodiazepine use in. This kind of merger, and all of these incidentally have been done in collaboration between USAP, who is very large, has a big national practice in community anesthesia, and academic institutions who have statisticians and methodologists and IRBs and things like that. And that kind of collaboration I think we'll see a lot more of going forward. And then finally, just one last slide here to talk about business. I mentioned workforce is the huge problem right now. You all know that. We know some of the causes. If you'd asked me a month ago, I would have told you the number one cause is non-operating room anesthesia, and the fact that we've been spread out, right? It's hard to run radiology anesthesia as efficiently as we run it in a 20-room operating room. It's hard to run a 2-room surgery center as efficiently as you do a 20-room operating room. And both of these things affect us. It turns out, though, that there's a second big reason. We just published on this. A lot of it has to do with hospital convenience, it turns out. And the hospital, although they're writing us very large checks right now to be there, they don't care as much about the money as they do about giving all their surgeons a 7:30 start time. So it turns out that we are very horizontal these days. Frank Dexter and I just published this in the Journal of Clinical Anesthesia. 82% of all the anesthesia in America is done at 1 o'clock in the afternoon. So the average anesthesiologist workday in America is actually an hour shorter than it was 5 years ago. And so we are very fragmented, very spread out, and that's one of the big reasons why we're very expensive right now. But it is, to some degree, a voluntary choice on the part of our customers, the hospitals and the surgeons, to function that way. So next time you're having that conversation with your hospital administrator, please feel free to bring that up. But the other thing I will mention, anesthesia is very, very safe right now. We've done an extremely good job of making it so. We should be proud of that. And it means that it's okay for some things to fall off the back of the table. We probably don't need to sit with every cataract patient today, especially if they're getting oral midazolam, a Valium or something, and a local anesthetic eye drop. And it's a waste of our talent. I mean, it's unnecessary from the safety point of view, and perhaps we can pull back some of those people and use them in smarter ways. And there's some other examples on the slide of things that we're looking at, but we are getting regularly asked to staff surgery centers in novel ways because it is very expensive. So can we run this 2 rooms with 1 doc and 1 CRNA? Is that safe? Can we do that? The answer is it's happening all across the country, I will tell you that, and it's as safe as we choose to make it. But this is a process that we as the anesthesiologists, as the experts, need to own, because if it is going to be safe, it needs to be us running it and setting the rules, selecting the patients, managing the protocols for all of these new models of care. So if you're not thinking about this with your hospital, you should be, because it is what's going to happen. And if we don't take ownership of this process, somebody else will, and we won't like the results. So I think with that, I'll wrap. Thank you all very much. And we do questions? I'll trade spots.
Okay, I think we have just a few minutes for questions. Does anyone want to come up to the microphone?
So I actually have a question for Rick. All right, it's very interesting, the figure of the 82%.
Yeah.
I just leaned on Vilma and said I don't know what is this about. This is definitely not where I work. And she nodded and she said, me either.
Right.
So where's that coming from?
Yeah, so obviously the data source is state of Florida data over a decade. Every case done in the state of Florida for a decade was the substrate for that discussion and the time trend over time. You can go read the paper. It's in Journal of Clinical Anesthesia. The answer is that your experience, and probably many people in the audience, is in a traditional academic hospital where you do run more vertically. And you're encouraged to use every minute, 7 to 5, and beyond that probably. And you do nights and weekends and stuff like that. What you don't see, but are being averaged with, is 100 surgery centers that are running from 7 to 3. And by 3 o'clock, half the rooms are empty, right? And they're winding down. And similarly, your radiology service, your GI, the stuff you're doing in radiation oncology, a lot of those are just daylight, just daytime, daylight kind of processes. That's what's going on. And it is almost as if we are becoming 2 different specialties right now. There's an outpatient daylight work, Monday through Friday, 7 to 3, anesthesia business, and there is the traditional hospital-based rescue, trauma, OB, emergency surgery business. And we are bifurcating right now.
Okay, excellent. You have a question?
Yeah, I have a question for Dr. Dutton. I'm Charles Plant. I'm from Mobile, Alabama. So we often get in a situation where, we're covering 4 rooms, everybody's covering 4 rooms, and then there's another case to start. And I've started just doing it, I'll start the 5th case. And so the billing changes from, medical direction to medical supervision. And as far as I understand, it's not illegal, it just changes the billing.
That's correct.
So I just wanted to know your thoughts about this.
Yeah. So you should do that if it's safe, right? And if obviously it's benefiting the 5th patient, the one who gets their case started now instead of waiting, it has to be safe for the other 4 patients. So it's very much a matter of individual judgment. And incidentally, what you describe is identical to every large hospital in the country right now at 3 in the afternoon. And whether you choose to flip from direction to supervision, the financial implications of that are much smaller than they used to be because of various payer policies, and half of your practice income is probably coming now in a direct stipend from the hospital. I use half as an approximate number. It depends where you are, what your payer mix is, but some amount is just direct payment, so it doesn't matter what you bill or in what ratio. But the financial implications of it are much smaller than they used to be, and the getting the work done implications of it are much larger. I mean, the pressure on us to get the work done is much larger than it used to be. So do I do that too? Yes, frequently.
Thank you.
I think that this is like a great opportunity for us maybe to get one or two more questions. Is one thing I wanted to ask you, Dr. Kasabani, is, I know you're working with a lot of different subspecialties. What are the next subspecialties on the horizon? You worked with OB, you worked with regional pain.
So we're gonna know that tomorrow, right?
Yes.
So we have, we put it to a vote, a list of the active committees in the ASA. We put that to the CPOM membership. Vilma and I, we do have an idea, but you always want to be, democratic, and you want, the vote to come from your own membership. So we want them to tell us, which committees that we're gonna be working with. But if you want the sneak peek, I think there is a lot of potential for the committee of neurologic anesthesia, right? And there is also a large potential for the committee on practice parameters and guidelines. And the committee on economics is something that we've never looked at, but then you see all the business aspects that Rick was talking about, and that also reflected in the questions. I mean, are these something that we can talk about, that very idea that you just heard, can this be converted into something that we can fold it into the fabric of our work to really measure, to see if this is going to translate into us doing a better job or not? But this is where we're heading right now. We have a wealth of expertise in this society, in the different disciplines of anesthesia, and we are determined to tap into every single one of these resources.
Yes, and I just want to say, one last final comment is that in terms of the MIPS program, if you have less than 6 measures, they want you to have a measure that really doesn't, involve health equity or efficiency. So I can definitely see us looking into the world of efficiency measures and seeing, is there a gap? Is there a best practice? So those are the things that we want to tackle in the future. So thank you all so much for coming. I think we're getting a hint that we have another lecture coming up behind us. Thank you.
Good job. Thank you.